Take their seats. We will get started in a few minutes. Okay. Good morning, everyone, and welcome. I am Joe Ruffalo. I am SVP and GM of The Hill, and want to thank you all for joining us in person and online this morning for this very important discussion on keeping pharmacy shelves filled, solutions to address drug shortages. I'd like to thank our sponsor, Healthcare Distribution Alliance, for their support of this very important topic this morning. In the first quarter of this year, there were a record 323 drug shortages in the United States. Shortages of life-saving cancer drugs, generics, and ADHD medications have dominated the headlines. Overall problems stem from demand exceeding supply, as well as manufacturing production challenges, especially in the generics market. Today, we are here to discuss meaningful solutions. But before we get underway, a few housekeeping rules. Please silence your phone if you're in the room. Also, please follow us online. You can follow us on Facebook, X, and Instagram at The Hill Events using the hashtag HillHealth. Also, if you're in the room, please be mindful of the cameras if you're walking across so people can watch at home. And with that, I'm delighted to introduce our first guest, Congressman Larry Bucshon, a Republican from the great state and my home state of Indiana, a senior member of the House Energy and Commerce Committee and vice chairman of the Health Subcommittee. Before coming to Congress, Congressman Bucshon was a physician and surgeon, and he joins Kathleen Koch, contributing editor of The Hill, to begin today's program. Thank you.
Good morning.
Thank you. Good morning, everyone. And thank you, Congressman, for joining us, or should I say, Dr. Bucshon.
Yeah, I always tell people, call me doctor, not congressman, because doctors are a lot more popular than congressmen. It's a true story.
They're more popular than journalists as well.
Yeah,
so.
well, what can I say?
So, Dr. Bucshon?
Yeah.
How frustrating is it as a medical professional to see where we are right now with these drug shortages? And I can't imagine the stories that you must be hearing right now from friends, even family. I mean, your wife is an anesthesiologist.
That's correct. Yeah, it's very frustrating, and it's a frustrating problem for the patients, of course. And so, for example, when we had a manufacturing facility shut down in India for carboplatin, which is a chemotherapeutic agent, a number of years ago, I have an oncology friend back in Indiana who called me and said, Larry, you need to can you come talk to me, because I'm actively having to ration carboplatin for my patients who are getting chemo as we speak because they were short on the drug. So that's, I hear firsthand from physicians. And then my wife, as an anesthesiologist, will tell me frequently that they have shortages of certain things called paralytic agents, which is one of the things she uses when they put people to sleep for surgery. And
what do they do about that?
Yeah, you have to try to find alternatives, and sometimes it's difficult. So this is a critical issue. Honestly, I've known about it since I started practicing medicine, 25, 30 years ago. So.
But it's gotten worse.
It has gotten worse. If you look at the numbers, it's 300 and some. I can't remember the exact number now, but whereas 20 years ago, it was maybe 40, 50 drugs that are routinely short. Now they're mid-300s almost daily, that there are shortages worldwide.
Let's talk about just shortages in general. And I know that you understand that there are different types, but I think it's important that we describe the difference, because we have the disruptions that occur because of a sudden shock, say a health emergency or a tornado or a hurricane, the level of plant. Then we have the ones because of unexpected demand. The type that we're seeing, say, with the ADHD medications, right. The weight loss drugs, Wegovy, Zepbound. And then there are the shortages that make up the majority. So 83% of the shortages are generally due to manufacturing production issues, primarily quality issues, and they affect largely generic drugs. So which ones are you most worried about? Which type of shortage?
Well, all of them, but the one that is related to the active pharmaceutical ingredients, or APIs, is really critical for the United States, because actually it's starting to go into the national security space a little bit. And what that API is, the active pharmaceutical ingredient, maybe 20%, at the most 25% of those are actually produced in the United States. The rest were dependent on production from around the world. And we saw during the pandemic how that can that can be problematic. So I'm concerned about that, particularly a lot of the manufacturing that happens in China because of the tension that we have from geopolitically with the Chinese, and they have threatened sometimes to withhold APIs. But it's just such a multifactorial problem. But I think one of the big ones that I'm worried about is the supply chain issues, right? And Doris Matsui and I, one of my Democrat colleagues on the committee, and you mentioned this earlier in our comments, have introduced legislation that will help get Health and Human Services to try to map this pharmaceutical supply chain in the United States so that we have better data versus disjointed data from different agencies, try to get it in one place.
Right, because I understand right now no single federal agency has a full view.
That's correct,
right,
and that's what you want to do.
U.S. drug supply chain start to finish, and that's a problem.
That's a problem, and that's what we want to try to do, is try to map that and then look for vulnerabilities. And, the API production overseas is just one of the vulnerabilities. There's all kinds of other economic related issues. There's multitude of reasons why we're drug. Let me just describe a couple of the reasons if I can. I don't want to get out ahead of you, but But for example, a number of years ago, my wife's an anesthesiologist. There's a medication called propofol. It looks like milk in a bottle if you've ever had, right? It was short for a period of time. The reason was because the only manufacturer was in Europe. And one of the states in the United States was planning to potentially add that medication to their death penalty medication, okay? Capital punishment. And the manufacturer in the country said, we will not send propofol to the United States if anyone is going to use our medication for capital punishment. So so not only is there,
Wow.
It potentially did, but they resolved the problem because the federal government had to say, well, you guys need to change your plans here because it's going to affect the entire, but that was because we had only limited manufacturing capability. So I'm using that as an extreme example of, there are the chronic issues, but occasionally there are things that hit in manufacturing for a variety of reasons. We had the plant in India shut down with carboplatin, as we described, right? All of a sudden,
was a quality issue?
It was a quality issue, and all of a sudden you have a worldwide shortage of a chemo drug. So, you described Adderall, which is being used for ADHD, right? The demand was unpredictably high. It has been because it was found by many physicians to be very effective. And all of a sudden, you have a bunch of people coming into the marketplace, and there's not enough manufacturing capability, not capacity. So those are just some of the reasons. Remember when we had a shortage of antibiotics for little kids that had ear infections?
Right.
Augmentin. Augmentin. It was actually not Augmentin, the generic version of it. Okay. That was because during COVID, not as many kids got ear infections. Okay, so when the manufacturer looked at this, predicting the future, they do projections years ahead of time what the demand might be. Of course, the demand was fairly low during COVID, but when we came out of COVID, all of a sudden the demand was high. But they had projected the amount that they would need, and it wasn't enough. So for temporarily, for economic reasons and manufacturing reasons, they were short. So it's a challenge.
How worried are you, though, about our dependence on countries like China, like India? I mean, right now, some 80% of the medicines Americans take every day are produced outside the U.S., again, with China and India being the biggest producers.
Yeah, I mean,
Is this a national security
Yep,
problem?
as I mentioned, it isn't becoming a national security issue. And I think that, if you look at the situation, it's a difficult one to solve because you have to look at the economics of what it takes. If you want to keep drug prices low, and we've dropped drug prices in the generic space very, very low. The ones you see that are very, very expensive, or in general, are not in the generic space. 90% of the drugs we take in the United States are generics, roughly. And so it makes it difficult if you're going to produce large volumes of generic medications in the United States or other countries where the manufacturing costs are higher. So then you end up having them produced in countries where it's much lower. Well, that's a challenge for a number of reasons. Number one, quality-related issues. Can the FDA keep up and make sure that the manufacturing facilities are up to our standards? And many times they are not. And who controls the export of the active pharmaceutical ingredient? It can get tied up in geopolitical disputes like we've seen during COVID with the Chinese. So not as much with India because they're a democracy and a like-minded country, but we did see with carboplatin that there was a quality issue. But that's where you get into the question: well, how far ahead should the FDA look? How many people do we have on staff at the FDA to make sure that we can have them all around the world? They are around the world, but do we have enough people? Do we have enough funding to make sure that the quality is there, so even if it's not produced here, we don't have these shutdowns? So
does the MAPS Act address that?
I would hope, yeah. The MAPS Act, with Congresswoman Matsui, is hoping to have a map of all of this, okay, the supply chain in one place, Health and Human Services, and then have the experts, and I wouldn't count Congress in that in many cases, the experts that know what they're doing as it relates to supply chain, as it relates to distribution, as it relates to manufacturing. Everybody together, if you have the data that you understand where the vulnerabilities are, then maybe you can address those. So that's what we need to do.
Let's talk about the generics specifically, and you've highlighted how they have these issues, and in particular, what we need to do, I hear so many people say, is quality. We've got to, instead of having this race to the bottom on pricing, you've got to find a way to reward quality. What are your thoughts on that? How do we do that?
You have to, but it's a free market. It's a free market economy, so you have, and it's a difficult challenge, because of course, a large population of the American people are dependent on these medications, and there's various degrees of the ability of people to afford them, whether they have insurance coverage. The other thing is the cost to the federal government through the Medicaid program, now Medicare Part D, and other programs. Of course, from a federal government perspective, we want to try to keep the costs down. But when you get reimbursement issues related to whether it's physician practices or the cost of medications, and you drive the reimbursement down too low, then you get into a situation where you'll have generics that just are not economically feasible.
Well, I understand some generics will cost only, the average price is between $1 and $8. And there's some companies that actually lose money making them. So when people talk about raising quality, I'm hearing some experts say we need to raise the price, which I know is something, that there's a disconnect. We go, wait a minute, we're talking about lowering drug prices. Why would we want to raise them? Because I hear there's such a high cost to these low prices because the companies can't afford to improve, to address the issues that the FDA highlights.
Well, there's two separate problems here. The generic space and the branded space are completely different. Totally separate. They're both very complicated. And so, the problem is in many cases in the branded space, when you have innovative products that come to the marketplace and you look at sometimes decades of research and development, and the economic case is made that the price has to be what it has to be when it comes to the market, right? And that's driven by a multitude of things, not just the pharmaceutical company or the distributor. It's a whole supply chain situation. The generics is somewhat different because the R&D costs and everything have been realized for the most part. Now, experts in that area don't criticize me for saying that, but the reality is that has happened when they were non-generic. So now we have a place where we have medication that needs to be available, but we're not looking at really recouping R&D costs. You want to not lose money, but you want to. And so where does that balance get struck, right? And again, from a federal government perspective, Medicare, Medicaid, and other government programs that pay for these things, you want low prices. But I do think in the generic space, in some areas, that the prices have been driven low enough that it's made it difficult to make the economic case for why people should continue to make these medications and distribute them.
How feasible do you think it is to really onshore medicine production to the U.S.?
It's going to be very difficult. And the main is it's driven by economics. I mean, it's not driven by ideological reasons. It's just driven by the economics, as I talked about before. It just costs more to manufacture certain things in the United States. And I'm not saying it shouldn't. That's not a judgment on wages or anything else, that in the United States. But that's just the facts. It's just more expensive to produce it here, or in some cases, European countries, and that's why they have outsourced the production to countries like China or Vietnam or other places. So it's difficult. It's not a simple solution to just say, well, why don't we just onshore all this? Or the other one is, why don't we just stockpile these? Why don't the federal government, things that are short, why don't we stockpile them? And it seems like a good short-term solution, but in the long run, the medicine's outdate. You don't know what the demand's going to be. The federal government could have warehouses full of stuff that goes bad, and you have to have a whole system to know which things outdate, and then you get rid of those, and where do they go, and then you got to bring in new ones. I mean, it's just not that simple. It's a complicated problem. I hope I get that across to everyone, that there's no one simple silver bullet here.
And with onshoring, too, isn't there the issue of our environmental laws? Because when it comes to making these APIs, the active pharmaceutical ingredients, some of them produce very toxic waste, right? So we probably couldn't.
That's partially true, yeah. I mean, the manufacturing, whatever it takes to manufacture these, there are going to be issues related to, energy use, what's the energy demand for the manufacturing facility, and as you know, we're trying to do all we can to get carbon emissions down worldwide. The United States, by the way, is doing probably the best job in the world, but that's why I think it's a difficult problem to solve, because it's not only the overall manufacturing cost to produce these in the United States is not one thing. You brought up, we want to make sure whatever we do here in our country, we're not putting toxic chemicals into the Potomac River, right? I mean, and so we should be doing those things. But we also want to make sure that people that are making these, people that are working these factories, are getting paid well, right, and have good benefits and the things that we know that we value here in the United States. And to do that, it costs a lot more money.
So what about friendshoring or nearshoring as an option?
That is a good option. I'm a congressional co-chair of the study group on Japan for the former members of Congress organization, myself and Congresswoman Diana DeGette from Colorado. And her and I travel to Japan every year. That's a classic place, potentially, as a friend that we could, have. And they're worried about the same issue, by the way, because a lot of their stuff, not only in the pharmaceutical space, but everywhere, comes from China, because it's really very close, right? But yeah, on friendshoring, I think, North America, friends like Japan, Australia, some European countries. I think all of us are trying to figure out how do we balance that and how do we make that happen.
And how important is redundancy? Because we had that tornado in, I guess, 2023.
Two of them right in a row that hit Puerto Rico.
Right. Yeah. Well, there was a hurricane in Puerto Rico and then the tornado in North Carolina.
Oh, the tornado, yeah.
Right. The plant, the pharmaceutical plant, that one single event put at risk drugs at hospitals you needed to block pain, sedate patients, and fight infections. So what do we do about redundancy?
Well, we need to work with the FDA and make sure that we can, for example, this is hypothetical. You have two manufacturing facilities. One of them has to shut down. The other manufacturing facility needs to have the latitude to, at least temporarily, produce more of a certain medication per day or per week, right? Above and beyond what they're certified by the FDA to produce. So there needs to be a little more flexibility there where you can ramp up. And that's one of the things coming out of COVID, as far as things like masks and all these other things, not just drugs, is that we need to have that kind of resiliency where if we need these things, we have the ability built in, with probably some federal support, built in so that we can expand our capacity in the short run. And we may have to make sure all the federal agencies have the flexibility to allow that and still, and still keep the quality there. And so resiliency within our own country is important, no doubt.
I mean, you mentioned federal support. Other countries, China, India, subsidize a lot of what their pharmaceutical companies do. We don't really have a level playing field, companies in the U.S.
Yeah, they also pay their workers pennies, to make the, in those countries, to make the products, right? And so, but there is, to your point, there's a multitude of reasons why it's more cheap to make these things in places like China. It's not just the wages, it's other things. Government subsidization, and some people have suggested here, I mentioned stockpiling earlier, right? And we have a free market economy. It's based on supply and demand and the free market. The way I look at it is, if there are places where the free market can't solve the problem, or voluntarily, then you have to start looking at things like where you subsidize things from a federal level. But as you might imagine, my feeling would be that's a potential snowballing financial problem that we could get ourselves into. And we have to look
Haven't we
closely
subsidized
at that.
other industries, oil and gas?
Of course we do. Oil and gas, renewables, that's just in the energy space. The federal government subsidizes everything. I mean, my local communities get their community development block grants to, fix things in their communities. The federal government is involved in that, absolutely. And I'm not saying that's not a reason to look at it. But we do in the tax space is an area we haven't really talked about, but we do have an opportunity there.
Okay.
To make sure that if companies are going to produce things in the United States, make sure that we're competitive, at a minimum, in the tax space. For example, whether the individuals that work at the companies or the companies themselves have a competitive tax climate and regulatory climate to work in. That is in a way subsidizing an industry. But it's complicated. Question.
Congressman, I noticed there are some 10 measures on this topic that have been introduced in Congress, 10 bills to help deal with this, and maybe there are even more. Maybe I missed a few when I was counting.
Yeah.
So why do you think this is such a unifying issue in these divisive times? And what do you think the chances are that we will get a vote on one of these measures soon?
I think it's the reason it's not that. Actually, there's some disagreement between the political parties on how to solve the drug shortages, but they're very, very small. Doris Matsui and I, she's my Democrat colleague that I'm working with, we're in agreement. We need to do something about understanding our supply chain and look for vulnerabilities, right? But it's unifying because pharmaceuticals affect every citizen in our country, all the way from newborn babies, all the way to our grandparents or great-grandparents, right? And it's such a critical issue because it affects people's quality of life. It affects people's ability to live a quality life or extend their life. In the case of like carboplatin, you're short on that. How'd you like to have cancer? And your oncologist say, well, you're gonna get half the drug this week that you would have because it's short. That's a real story. My oncology friend told me that. So that's why it's very personal, and it should be. And so I think members of Congress on both sides take it that way and understand that this directly impacts everyone. And then if you look at the individual, that snowballs into how are we as a society. If you don't have a healthy populace, then you lose productivity. It affects everything, right? It just affects everyone, and that's why it's so personal.
We have some audience questions, or at least I think we have time for one that were sent in early. So Lisa, if you could read us the question.
We have one from Christine Lee from Friends of Cancer Research. Is finding balance between innovation, progression, and affordable drugs possible? If so, what does it require? And what can Congress do to actively support this balance?
That's just such a simple question. I don't know how to answer that. As we've talked during the talk, I'll just say this. It's a delicate balance. I mean, I take it this way a lot, is that there's a lot the federal government can do, like mapping the shortages and knowing where where the deficits are and then working with the industry to solve those problems, right? But I also don't, I'm just giving my own personal view, but I also don't see, for example, some people have suggested that the federal government manufacture medications ourselves, right? That doesn't solve your problem. And again, you get into the stockpiling issue and the challenges there. So there's, I think that the thing that Congress can do is help show everyone the data, get that message to the American people, and then work with everybody all along the pharmaceutical supply chain to try to solve some of these problems as it relates to the deficits that we would identify in the supply chain. Again, it seems like it would just be, well, why don't we just, every medication, why don't we just subsidize the cost for everyone? And the reality is that when you at the end of the day, I just don't see that solving the problem. It makes it probably maybe even a little bit worse, because it's a short-term solution for really a decades and decades long problem. We started having this problem many, many years ago. But the one thing I will say, it is a unifying problem for Congress. We do have some differences in views on our committee, the Energy and Commerce Committee. But for the most part, everybody is working towards the same goal. The American people should know that. We're working towards the same goal of trying to be helpful where we can be, but also working closely with the private sector from top to bottom to try to solve this problem.
I'm Indiana Congressman Dr. Larry Bouchon.
Thank
Thank
you.
you so much.
Oh, thank you.
Appreciate it.
Thank you.
Please welcome to the stage Chip Davis, President and CEO of Healthcare Distribution Alliance, in conversation with Joe Ruffalo, Senior Vice President and General Manager at The Hill. But first, we will start with a short video from our sponsor, HDA.
Healthcare distributors deliver 10 million medicines to pharmacies and hospitals across the country every day. Our industry supports providers and pharmacists, ensuring patients have the medicines they need when they need them. We're problem solvers. When drug shortages occur, whether due to manufacturing issues or surges in patient demand, we leverage our expertise and partnerships to lessen their impact. And we're committed to making the healthcare supply chain even stronger. We are health delivered.
One moment, please. Sorry, small technical difficulty.
Well, thank you for being here today.
Thanks, Joe. Thanks for having me.
Before we jump into the conversation, can you tell us a little more about the Healthcare Distribution Alliance and the role your members play in the U.S. pharmaceutical market, and really how distributors differ from, let's say, a PBM or a GPO?
Sure. Yep. Happy to do so. And thanks for everybody for being here and those that are participating virtually. HDA is the organization that represents primarily healthcare distributors. We have 40 full-line healthcare distributors based throughout the United States. And our members essentially live at an important nexus point between what we like to refer to as upstream, the manufacturing community, branded manufacturers, generic manufacturers, biologic, biosimilar manufacturers, specialty drug, and the provider community. So we interact on a daily basis in terms of our member companies with about 1,400 to 1,500 manufacturers every day. and then do something that's very unique in the supply chain between the manufacturers and the frontline providers. We take legal ownership of their medicines, we take physical possession of their medicines, and then we take financial responsibility, because once it transfers, it's our medicines to then ensure the safe and effective distribution downstream, whether it's to pharmacies, hospitals, physicians, and the like. So we connect the roughly 14 to 1,500 manufacturers to 330,000 points of care on a daily basis, and sometimes multiple times a day.
So the topic of shortages is obviously very top of mind. From a distributor sector's perspective, what are the primary factors that are really leading to this?
Yeah, I just would reflect on Congressman Bouchon and Dr. Bouchon's comments. I do hope Congress can rally the call to do something before he leaves Congress at the end of this year, because we need experts like him in leadership positions. I think he covered it well when he said the equivalent of, if you've seen one shortage, you've seen one shortage. There are many that are demand driven, and he talked a little bit about some of those. The GLP-1s most notably, like Wegovy and Ozempic. But there's a lot of supply side, and that is due first and foremost, as the FDA has said in its own drug shortages report, due to manufacturing issues and heavily dominated within the generic space. So I think it's really important for everyone who has a lens and a role in this, starting with the manufacturers, but certainly not limited to them, to the role that we can play, to the pharmacy community, because at times it can be the frontline providers, such as pharmacies, independent community chain pharmacies, that are going to be the ones who begin to experience, let's say, a surge in demand that they can report upstream. So there's good communication within the supply chain, but I think there's an opportunity for even more regular communication to improve it as we move forward.
So what can we do to not only prevent these, but really minimize the impact on patients when they do occur?
Yeah, I think that's where our members play an incredibly vital role. They are really the logistics experts within the supply chain, because they have that visibility to what the manufacturers are seeing and feeling and communicating to us, as well as to the downstream providers. Oftentimes when a shortage occurs, I know there's a lot of talk about what happens in between a manufacturer and a frontline provider, and the role of quote unquote middlemen, to the degree that that term has sort of been negatively politically hijacked. I'm a lawyer by training, so I like to think of distributors as more as a learned intermediary because of the things that we do. But I think it's the ability for us to be able to communicate that, and when a shortage occurs, oftentimes we're the first person somebody calls. And that applies downstream to the pharmacy community, as an example, or the hospital or healthcare system, but it also applies to the manufacturer. If they run into, let's say, an inspection problem with the FDA, whether it's domestic or abroad, they will call the distributors and say, you're not going to be able to rely on us for X period of time moving forward. You need to seek additional suppliers. The other thing I would disavow is at times in this idea of a race to the bottom, that distributors only utilize one supplier. We can't. The reality is drug shortages impact our business every bit as much as they do anybody else's within the supply chain. We want medicines moving, we want product shelves filled in order to be able to do what we do on behalf of our trading partners and ultimately patients. So we source multiple providers, and increasingly are looking at things beyond cost, such as their resiliency, their historical track record, their ability to meet demand, their quality ratings is an issue that the FDA is working on, but their history of quality manufacturing are all factors that distributors look at when making decisions who to partner with.
So generic drugs, we've talked a lot about them. They seem to be a major piece of this. More than 80% of the shortages occur in that class of drugs. So how do distributors support a more robust and sustainable generics market?
Yeah, I think there's a couple of ways that we do that. I think first and foremost is recognizing that the generic industry, and this was touched upon again in the previous discussion, is a significant, overwhelming majority of prescriptions in this country. It's about 90% of all prescriptions and less than 20% of the cost. Year over year, those trend lines increase. The percentage of prescriptions go up, the percentage of costs go down. That's probably good for the healthcare system to a degree, right up until we're at 100% of the scripts and 2% of the costs, and we don't have a generic industry. So I actually think there's a lot of discussion between, let's say, manufacturer, or the debate about manufacturers discussing with distributors and other frontline purchasers about how to further stabilize the generic industry. We welcome that, but what I will tell you is the conversation cannot be limited to those two entities. We have to bring in the provider community, and that includes pharmacies, physicians, hospitals, healthcare systems. It actually includes society and policymakers as well, right? I think as we've heard, like, what's the debate been for the last 20 years? How to lower drug costs, not how to stabilize and potentially increase drug costs in the generic industry or anywhere else. We're not averse to that conversation. We think in certain instances it clearly needs to happen because of some of the experiences that we've had. But make sure that you're bringing everybody in, because I guarantee you on Thursday night in this presidential debate, no one's going to be talking about increasing drug costs. Both President Biden and former President Trump are going to probably talk about what their administration has done to lower drug costs.
So finally, like from a policy perspective, what solutions are there to really solve this? And from a public and a private sector, what can they do to work together to solve this?
So I think there's a number of proposals that are out there, some coming from the administration, some coming off of Capitol Hill. I think within the administration, the Department of Health and Human Services earlier this year released a white paper talking about potential resiliency programs, both for manufacturers and for hospital systems. I think the latter is particularly focused, given the propensity of shortages in generic sterile injectables, focused on the health system space where they're predominantly administered. And so there's a conversation there about how those programs, what those programs could look like, what would HHS need to do, what would FDA, CMS need to do, as well as what the private sector would need to do. And on the Hill, as was alluded to as well, there's a lot of proposals. Congressman Bouchon said that this is a bipartisan issue. I agree with him. I think his work in the Energy and Commerce Committee has been and continues to be important. On the Senate side, the Senate Finance Committee, with Chairman Wyden and Ranking Member Crapo, have been working very closely, and their staff have been great in trying to put forward some ideas about how to potentially empower the Secretary of Health and Human Services based upon predictable shortages to empower everybody from manufacturers and everybody else in the supply chain with appropriate incentives for the limited number of drugs that they see are in shortage or they expect could be in shortage moving forward. So I think part of it is just getting, quite frankly, the political momentum behind some of the good policy ideas that are out there to move them forward.
That's great. Well, thank you so much for your perspective and your insights in this.
Sure, thank you.
Appreciate it.
Thanks.
Thank you.
Please welcome Kathleen Koch back to the stage. She is joined by Dr. Mark McClellan, former FDA Commissioner and current Director of the Duke Margolis Institute for Health Policy.
Hi, Mark. Thanks for joining us this morning.
That's great to be here, and nice to see such interest in this really important issue.
It really is. So you heard what the congressman said, or what our last guest said. When it comes to the drug shortages that we're experiencing, does that jibe with what the Duke Margolis Center for Health Policy has found? I know you did a recent report on that.
Yeah, it does. We formed a consortium last year on drug supply chain resilience and advanced manufacturing, in part because of the worsening challenges that we're seeing in important parts of the drug supply chain and availability of critical drugs, especially for hospitals. So the reports that we've done, the ideas that we've heard about already today, Dr. Bouchon has legislation on trying to increase transparency about what's going on in the supply chain, where drugs are coming from, availability. This builds on programs that FDA already has in place. They have a whole team that monitors drug supply chain issues and tries to prepare for shortages. More information would potentially help there, but as you just heard in the last discussion, it's not just about information on the supply side and the supply chains, but also the supports available in the market for having a reliable supply of drugs. We were just talking about everybody wants lower drug prices. Most of the drugs involved here are generic drugs, and within that, generic drugs that are hard to manufacture. They're injectables that have to be made and maintained under sterile conditions, so it's even more sophisticated manufacturing. And these are drugs that there's not patent protection in place. There can be a lot of competition to really get to low prices.
And they've been around a long time,
They've
right?
been around a long
70s.
time.
I know some that have been in shortage recently.
Yeah.
Were developed 70s, 80s. But
Yeah.
can you help us understand, why is it hitting this crisis point now? What has really happened?
Well, a lot of these drugs have been in shortage for a while. So for some of it's a chronic problem. It is getting worse, I think, because of these
record levels, right?
Record levels of pressures on the market. The majority of the drugs, the 300 plus that are in shortage now, cost less than $1 per dose.
Less than a bottle of water, right?
Yeah, we're not right. Way less than a bottle of water. You can't get a good cup of coffee for this price. And even the more complex, these injectable drugs, it's like $4 or $5 per dose. So one thing that's important for people to remember is that in contrast, or the usual problems they're worried about with drug
right. They
pricing
can't
being
afford
high.
it. They cost thousands and thousands
So the
of dollars.
question is, in this case, where we've got anybody who meets reliable manufacturing standards can participate. It's just that the prices are such that they're not able to sustain at a large scale reliable manufacturing. So basically what's going on is that FDA takes a lot of steps to make sure that if a drug gets into a hospital and gets into a patient, it meets the FDA standards.
Of course, that's their job.
That's their job. The problem is that because the manufacturing process is complex and you have to source the ingredients and things like that, there's just very little margin. It's not profitable or sustainable for many of these manufacturers to invest in not just quality for the drugs that make it into patients, but reliability so that the drugs will be consistently supplied. And
so how do we change that?
So we change that by the things like Dr. Bouchon has been talking about on more clarity about reliable manufacturing is important. FDA has some new programs like a quality management maturity program on quality manufacturing to try to get the quality up. But
so would companies get like a quality score?
Yeah,
perhaps
and more,
they would be favored.
More transparency
in the
about that,
okay.
so that when hospitals and we heard from the distributors and kind of purchasing organizations that buy drugs, just like they buy other supplies on their behalf, they'd have access to better information on not only is this drug that you're actually getting today meet FDA standards, but is this manufacturer and their distributors supplying these drugs reliably, consistently, so that the patients who need them are going to have them. This is an industry where hospital care, you need reliability for the operations, for the chemotherapy.
And
it's
quality.
Not just quality, it's quality of point in time, but it's reliability over time. So better data will help, but the other big problem is that we don't have a market that really rewards reliability. So the way a lot of these contracts for buying drugs are set up, hospitals might have, or their purchasing organization might have an arrangement with a manufacturer, but if they find a lower price on the market today, the contract's going to let them go take that lower price. And see, if everybody's buying drugs that way, it doesn't create a very good environment for the manufacturers that are trying to do it
How can
reliably.
they really run a business
Exactly.
and plan? So we need to change the way we contract?
That's right. So
Okay,
the way we think of it is it's a demand problem as well as a supply problem. We've got a market that's doing a good job of getting really low prices and a not so good job of getting really reliable supply. To fix that, we need to shift the market and get availability of good information on reliability as well as quality of the manufacturers and their supply chains, and link that to contracts where the norm, not the exception, is purchasing for reliability. And there are examples of this in the United States now. Civica RX, all of the government purchasing organizations, the major ones now offer this option. It's
Now, people don't know who Civica RX is. You need to explain that.
So this was an arrangement supported by, and I should be clear in terms of disclosures, we get funding from the West Health Foundation. They're very committed to trying to make essentially healthcare markets work better, more reliable, low-cost, high-quality care. They've supported a collaboration along with other foundations and some hospital systems to get to a reliable manufacturing supply. So Civica RX is basically committed to manufacture in the U.S. And they've committed to supply these drugs that are often in shortage and are critical for hospitals, and they do it in a different way, which is not just, we'll produce drugs and put them on the market.
Right, not the
and help
race to the bottom for the lowest price.
And compete on price, but we'll get into contracts with hospitals and health systems, so like Kaiser, Intermountain, participate in this program. And what they get is they pay a little bit more, but we're not talking about, thousands of dollars more. We're talking
$10
about,
instead of $8.
Yeah, or even less, like 10, 20%, 30% higher. But in return for that, they get a committed contract where the manufacturer, in this case Civica, says we will supply this drug. We will face a financial penalty if we don't deliver it, every day. So there's adequate supply whenever you need it. The flip side for the hospitals is that they're a little bit more committed. They're kind of locked into paying for this contract. So that might mean, well, today it's $4 rather than I could get it on the spot market for $3.25. But in return for that, 75 cent, 25 cent, whatever difference in price, they get reliability and their patients get reliability.
And I understand some studies have been done that show that in the long term, that is actually saving them money, the hospitals across the board.
I think that's right. It's when you don't have the drugs that you need, and the drugs that are in shortage, there's a big cost to that. So these are drugs that are used for anesthesia, for pain control. So you don't do the operations, or if you do the operations because they're emergency operations, you're more likely to have complications. They're chemotherapy drugs for kids, for adults with serious cancers. You don't get the right, best treatment for the cancers, that's going to mean higher costs of complications afterwards, as well as patients having to stay in the hospital longer. So this is an approach that should be sustainable. It's just we need to kind of jump together to a new way the market works, where just like so many other things, as that hospitals buy, they focus on reliability. They have backup generators, they have backup staff, and all that costs extra, and it's built into the cost of a hospital. Say why? Because that reliability is something you need in these very serious services that hospitals provide for serious conditions. We just haven't done it yet for these mainly generic drugs and injectable drugs that are repeatedly in shortage and causing these ongoing problems in quality and reliability of healthcare.
Sounds like you're talking about a real paradigm shift from the fail and fix responsive mentality to really a preventive state of mind,
and
right?
I hope it's not something that people regard as too complicated. And I think the good news here is, as you heard all morning, this is an issue that has bipartisan interest. There seems to be emerging consensus around how to approach it. We're not the only ones who have been working on this. You're going to hear from a panel in just a few minutes, people from Brookings, elsewhere, who have really thought hard about this too, with solutions that are in a similar direction. And it basically includes, we've talked about good, reliable information on manufacturing quality and supply chain reliability that people can use to find reliable manufacturing and distribution partners, coupled with good contracts, committed contracts that help assure that the hospitals and their purchasing organizations, distributors that get the drugs on their behalf are buying from those reliable manufacturers. It doesn't have to be for every single contract, but just enough to make a big shift in the market. That is going to cost a little bit more, and that Senate finance bill, the bipartisan one that we're just hearing about, includes a provision for bumping up essentially the payments to hospitals when they make this shift and trying to do it in a way that's not too burdensome. So we still have a lot of kinks to work out here on getting the supply transparency right, getting the right kinds of contracts and supports and reliability in on the demand side, and coordinating all this. The White House is involved as I set up a coordination steps. HHS is coordinating across, this is FDA, CMS, our emergency response efforts at ASPE. So we're getting there, both through the steps that the administration is taking and this very important bipartisan legislation.
Congressman mentioned tax incentives. Do you think those play a role?
I think tax incentives could. The challenge here is targeting it to where we need it. So tax incentives for manufacturers that supply reliably could help, but just tax incentives for manufacturing in general, or just like increasing prices, that's probably not going to be enough. Yeah, you want to reward
targeted.
Yeah, you want to reward reliability. Just paying more for manufacturing that doesn't necessarily get reliable supply of the drugs we need isn't necessarily going to solve the problem.
What about onshoring? What are your thoughts on that?
So there has been a lot of discussion about the national security implications, not only for these critical drugs, but for all of our increasingly sophisticated advanced medical technologies. And that's a very important discussion to have. I do want to make a distinction between having supply that comes from the U.S. or or nearshoring versus having a supply that's reliable. We have seen drug shortage issues and manufacturing reliability problems arise from manufacturers everywhere in the world. China and India for sure, but also Europe, United States. It's really these underlying features of a transparent market linked to strong supports and a norm of buying reliable drugs that makes the most difference. So I hope as we go forward on this, we'll think about a diverse and robust, resilient supply, but it's not so simple as just saying, well, if we just make this American, the problems will go away.
You were FDA commissioner for 2 years, and then 2 years later, you were head of administrators CMS,
Yes.
Centers for Medicare and Medicaid Services. Anything specific that those two agencies could do, could change about the way they operate that would improve this system that you haven't already mentioned?
Yeah, I think it's some of the things that we've already talked about. So FDA, historically, if you look back at this issue over the past decade, a lot of the responses have focused on, well, the quality's low or the reliability is low. FDA want to just regulate more. So FDA set up, like I said, that quality management maturity program and steps where they can kind of document, at least on a pilot basis, which manufacturers are good. But if the demand isn't there, if people aren't paying a little bit more for reliable supply, not just quality drugs, then those steps have a hard time getting a response in industry. They can't, if they can't sustain their manufacturing at this higher cost of being reliable, then the FDA steps by themselves aren't going to make a big difference. So it's a necessary step, but not sufficient. That's where CMS comes in. CMS oversees, not just pays for medical services, and like I used to tell my staff when I was there, you're the nation's largest public health agency, right? Because how we pay makes such a big difference. And CMS right now has paid for, especially for these hospital drugs, just a whole bundled payment that doesn't pay a lot of attention to whether or not the supply is reliable or not. And the Senate Finance Bill, our proposals, some other similar proposals that are out there are all about, well, how can we change that? Have a focus, just like CMS focuses on, you've got to have reliable electronic records, you've got to have adequate staffing. What's the least burdensome way to help give hospitals the financial support they need and the accountability for having reliable supply of drugs too?
I know that your report on the drug shortage also looked at what the federal government was doing and what was working and what wasn't.
Yeah.
Because we have had more than a handful of federal agencies addressing this over the last 10 years, and it doesn't seem to have helped. What hasn't come together? What did they pass? Excuse me, the wrong measures or the right measures, and then they didn't get implemented properly?
They passed measures that were well-meaning for addressing pieces of the problem, but as we were just talking about, it's not sufficient to have higher regulation and more disclosure requirements on manufacturers about their supply practices. And by the way, there also are a lot of private sector sources of information too. U.S. Pharmacopoeia, IQVIA, they provide a lot of data on this as well. But if there's not a market that works, then that information, even if it is available, won't translate into reliable supply. You can measure things, but if the funding isn't there for people to use it, for hospitals to contract based on more reliable supply, then it won't make a difference. Recently, in the last couple of years, and this reflects some of our recommendations too, the administration has put together these different pieces like you were talking about. So FDA, ASPR, emergency response, ASPE, the planning and evaluation groups, other parts of HHS that have relevant programs into a more coordinated assessment of what's going wrong and what can each of these agencies do to help. And in the last couple of years, very importantly, Mina Seshramani, other leaders at CMS have gotten much more actively involved in recognizing that the CMS leverage here to help us shift to a market that, CMS is doing this in other areas too, trying to promote better quality, better outcomes, lower costs, not just paying for specific services services at the lowest possible cost. It's a theme at CMS now. So it's putting all that together that I think is different. And then Congress needs to support it with adequate resources and the right kinds of authorities to back all this up.
Wonderful. Do we have time for a quick question from the audience? It's pre-selected. Go ahead.
This one comes to us from Randall Letter. The best available government data on shortages is from the FDA, which reports when it declares they start and end, but not the difference between demand and supply, even though such differences clearly matter to healthcare providers and patients. Is additional reporting by the FDA or another agency necessary for the identification and implementation of sustainable and effective anti-shortage measures? And if so, what measures are necessary for the FDA to report more fully about the shortage?
So there are several legislative proposals and steps that FDA is trying to implement to get more data and transparency. That QMM program I mentioned, that's about kind of the quality of manufacturers, which would really help with supporting these kinds of contracts. I think the challenge is that program isn't very well funded now, and you heard Dr. Bouchon talk about need for more transparency, and I think bipartisan congressional interest in shoring up that information side on the supply and the manufacturing of these drugs that are likely to be in shortage would help. But it's not just that. We also need information on how hospitals are buying the drugs. And again, if they're just buying mainly the cheapest drugs available today because that's what everybody else does and that's what the market currently supports and encourages, we're not going to get there. So more transparency, and this is in the Senate Finance bill, of asking hospitals, and again, I think they, working with their suppliers, the distributors, the group purchasing organizations, these are large organizations that have a lot of data on reliability of manufacturers and contract terms. So we need probably some transparency there. You know, are you, hospital, using a reliable way of assuring that your drugs are not only safe and meeting FDA standards today, but they're reliably being provided. So some transparency there. The challenge with the Finance Committee bill is we need to do this in a way that minimizes burdens on healthcare providers. The hospitals, you know, they're stretched now, and I think there are ways to do that. We've given the Senate Finance Committee some suggestions about working with the GPOs, those purchasing organizations, and the distributors who have a lot of this data anyway. So putting those two together, that's, I think, the right kind of path forward. And again, it's not just us and our consortium with these proposals, but I think you'll hear more about similar ideas soon.
All right, Mark McClellan, thank you so much, Director of the Duke Margolis Institute for Health Policy. Thanks for joining us.
Great talking with you. Thank you, Mark.
Thank you.
Please welcome our panel of experts to the stage. Dr. Marta Woszinska, Senior Fellow at the Brookings Institution Center on Health Policy, Michael Kleinrock, Lead Research Director for the IQVIA Institute for Human Data Science, and Heather Zink, President of the U.S. Supply Chain for Cencora. Full transparency here, they are a member organization of our sponsor, HDA. Welcome.
Thank you. Thank you all for joining us. Well, I want to start, Michael, with you. You heard the previous 2 or 3 conversations this morning, and you're a data guy. I was wondering if you, when you look at IQVIA's numbers on the shortage crisis, what do you find is behind the drug shortages that we've been experiencing, and does it comport with what the other panels say is responsible?
So I was a history major, so I hoard like bits of data going back a long way. We did a report back in 2012 on shortages. There were causes, there were outcomes. When we revisited this last year, we saw similar things, but what I see is shortages are being caused by market events. And primarily what this is we had a backlog of generic manufacturer applications to bring generics to the market. So we fixed it. So FDA approved a whole bunch more generics over a number of years. Normally it was 300 or 400 new generics approved each year. They doubled that for 7 or 8 years. If you're late to market in an old generic, what's the number one way to get market share? Take the price to the floor. So what we saw in these shortages, we saw an intersection of 2 or 3 key things, but one of them is a big dominant market share player in an otherwise commoditized market and a poor business decision. Generally, being shut down from an inspection is a poor business decision. This is a for-profit industry manufacturing drugs. If you can't do it profitably, it's because you did something wrong. There's other industries like that. So that's really what's happened, is you get somebody into a dominant position and then they tripped. That's what's caused a lot of these sterile injectable shortages. That's what's leaving us exposed. We talk about shortages as if they're all the same, but they're very, very different. And there's a totally different story I would give about ADHD or about GLP-1s. There's a totally different story I'd give about those. There's also shortage needs defining. We talk about 300 plus shortages, but those include stockouts. Those include the supply being in the supply chain, but actually in the wrong spot. So what we found in our report is that most of the time when a shortage happens, there's more volume showing up in our data than there was before it was announced, not less. So, you know, Americans, we think shortage means I can't get something. And that's true, you can't get it, but that doesn't mean someone else can't. That doesn't mean that it's not sitting somewhere else in the supply chain serving patients with shorter waiting lists at certain hospitals. I was on a panel earlier this year where they were discussing where these chemotherapy shortages were stopping procedures in cancer patients for small community clinics, but larger cancer centers were largely unaffected. So where the drugs go is also important. And so when we talk about opacity, we talk about complexity, multifactorial. I mean, I love all the words. This is what I'm a data guy, that's what we do. And yes, it's complicated.
Marta, I know that people watching this, patients, their families, they have been clamoring for Washington to do something. And I know that your organization has put together a framework to guide policymakers at the national level on where and how to intervene. So what do they need to do? And that's a big question.
Yeah, that's a big question. If I could back up and say that, you have heard that different shortages require different approaches. I categorize them into two major buckets. One is the existing persistent shortages, of which largely are generic sterile injectable drugs used in hospitals. That's really where we need to be focusing.
63%.
63%.
Right.
This is what the Senate Finance Bill is doing. So when it comes to existing, sort of the persistent shortages that we have been experiencing, the Senate Finance Bill is the very first real step and serious step in addressing those kinds of shortages. And then there are the potential shortages. There's a lot of concern around our exposure to China in supply chains. We have yet to have a shortage that was caused by export restrictions. It hasn't happened. It's possible. It hasn't happened. The discussion about APIs, that's a very rare occurrence that we would have a shortage because of API shortages, but it's a very possible one. So we have a pretty good sense of the scope of the problem and which drugs we should be thinking about when it comes to the ongoing shortages. And the Senate Finance Bill really nicely tries to move us in this direction and try to solve the problem, the root causes of the problem instead of the market dynamics. Where we need to prioritize and where we need more visibility and where we need more strategy is the potential shortages. Just think about how many drug products there are. There's probably, there's multiple thousands of drug products, each with a different supply chain, each with a number of steps throughout the supply chain. How do we think about, we need to think about prioritizing this. There's no way for us to onshore all of the facilities. This has been said already. And so then the question is, how do we prioritize? And so this is, for example, where I see the MAPS bill being helpful. We have previously published a framework for how to prioritize and with colleagues and how to think about this. And we propose sort of thinking about three elements. Criticality, so is it medically necessary? Reach, so how many patients does this affect? And then also vulnerability. The MAPS bill would help us assess potentially the exposure of where the drugs come from and sort of assess the vulnerability. And using this kind of a framework, we can then start thinking about where the government would need to invest. Again, economics is driving us outside of the United States, we would have to reverse the economics if we want to reverse these trends. We would need to basically create subsidies one way or the other for that. And so again, how much money are we willing to spend on this? So let's be smart, let's prioritize.
Heather, let's talk about distributors. Help us understand the role that distributors play in the supply chain in preventing shortages, in reacting to them, and how important is really coordination and collaboration throughout the supply chain?
So coordination, collaboration is really what the distributor community does every day. We take very seriously that we service, as we said, 1,400 to 1,500 manufacturers every day. We're receiving inventory inbound into our distribution locations, and also coordinating with multiple sites of care. And when we say a site of care and a healthcare professional, which, full disclosure, pharmacists just paid off the student loans, so my mom's quite happy with me this week. But needless to say, we're talking about large academic health centers. We're talking about an independent pharmacy in a small town. I grew up in a small town in South Dakota, and I take very seriously that my family receives pharmaceuticals from a small, independent, local entity. And we see collaboration also as an access point. So our role is, how do I provide access for multiple sites of care, multiple sites of entities that are providing care in the community? And it could be complex care. It could be an anti-cholesterol medication that's an oral solid, all the way to a clinical chemotherapy agent in the local community. And so realistically, we are, I heard earlier today, we're one of the first calls. And we are. And we take very seriously that connection with our manufacturer partners to say, if they would come to us to say, hey, we're going to have a little bit of a bump in the road with the amount of inventory that we can put into the US market. It may not meet the needs of the demand of the certain sites. Can you help us? And I'll say a word, it sounds like a swear word and punishment, but we use something called fair share allocation. So we make available to multiple sites of care as much inventory as possible versus putting it into specific, maybe large density areas or large academic health centers or large entities. We really do try to look at, and every single day make inventory available so every site of care can care for the patients that they have. I'll say it's somewhat of the gift that is not always the best to receive because we don't please anyone.
Right.
No one is happy. In a town where a good collaborative event, I think, is nobody actually gets a victory, everybody gets a small win. That's usually what we're going for every single day. But it is very complex. We have a lot of different places in the market. And we really also take seriously as a supply chain, how much efficiency can we bring to this? So how do we balance access and efficiency and solutions in the marketplace to provide that local care? We take it very seriously.
Michael, planning ahead by having buffer inventories is something that we've talked about a lot. What have you found regarding the effectiveness of that strategy?
Well, I've heard a lot about buffer inventory strategies after shortages, but we had them all before the shortages affect these molecules. So everyone had a buffer. We plowed right through it and distributed it before the allocations came into effect. So I think a lot about checks and balances. If there are buffers at the manufacturer level, how they get to the distributor level and then how they get to the purchasers is really what this is about. One hopes that we have thoughtful and an appropriate interpretation of where those buffers should go everywhere. One of the challenges I think for distributors is if not all of them are perfectly aligned at that moment, then somebody's going on to allocation, somebody else isn't, and they're getting a sale. When somebody is humanely getting some stock for their hospital. And it reminds me and it forces me to sort of reintroduce this topic, which is not every purchaser at the end, not every hospital, if we're talking about hospital injectables, not everyone has the same resources. And so as a result, the ones with more resources have the ability to have enough stock on hand, have enough resources to serve more patients. And a smaller community center can't get there, and they're often the ones who suffer the most.
Yeah, I wanted to link it to an earlier conversation and make a distinction between stockpiles and buffer inventories. Right. A stockpile is when you take the drug, put it into a warehouse, you lock it up, and if there is a trigger event, a public health emergency, or you unlock it and you distribute it. Right. what I think we are talking about, and what we think is a better strategy, is to have a buffer inventory where instead of holding a certain, if that a wholesaler, instead of holding 10 days on hand or 30 days on hand, they will hold a much higher level on hand, and it's first in, first out. So there's no product that expires and can move through. And if there is a shock, there's a way to sort of have, it's a buffer, right? There's an ability to there's some inventory to work with. So I think I wanted to
enough entities that have those buffers? And if not, how do you encourage it? Because it's costly.
That's right.
You're keeping more on hand than you need.
That's right. So this is, again, if as the government is thinking about how to engage, we have previously, through some of our work, we have proposed having the government subsidize buffer inventories. And there are actually bills in Congress that propose something, those kinds of ideas, is to have, for certain types of drugs, for wholesalers to actually carry a higher level of inventory on hand. CMS has similarly proposed for hospitals to carry a higher inventory on hand. I think a lot of people who are actually in the field, in the supply chain field, will tell you that it's a very inefficient way to have the end users have allocated inventory. It's a much better, much more efficient, and much less costly strategies to actually hold it upstream, either with manufacturers or with wholesalers. But CMS, in a sense, has to work within its own system. They pay hospitals, and so this was the only way for them to do it. So I think it's not the stockpile as a solution. We should be thinking about buffer inventories, and they should be held upstream.
Heather, do you agree with what Marta said?
I do, and I think one of the key things from being solution-minded in this space is the distributors of the wholesaling community in the middle. We could turn that inventory, because again, we tend to hear stockpile is, I somewhat joke, it's in a bunker in the middle of maybe Nebraska, and when we need
can't stockpiles contribute to shortages, right?
They can potentially. And so I think that we're really looking at, from that buffer side, can we move the inventory so there's never any expiry date, so we don't also, again, we're all in an environmental mindset on top of that. It would be a much greener also way to have inventory move through the channel and balance that expiry date that's precious in the market also.
Let's talk about onshoring. Michael, how important a part of the solution is onshoring?
I think it's a distraction. The economics that have driven businesses to favor lower cost of production are still here. If we take the long history view from Hatch-Waxman back in 1984 to today, we all assume that we have 90% generics, that as soon as a drug goes off patent, it immediately becomes generic, and we get to pay pennies on the dollar, and it's fantastic, and drugs are cheap, and you can get your cheap prescriptions at Walmart, and it's fabulous. No one's ever followed that out 3 or 4 years past the patent expiry, when you have a drug that's 10, 20 years generic and making nobody any money, which is what is causing these shortages. What we have to realize is that this is not an economic thing worked out at a single drug level for a manufacturer, for a distributor, for anybody. It's a portfolio, it's an inventory. Generic companies make money by feeding on slightly higher prices as the drug erodes in that 12-month window immediately after the patent expiry. After that, it's a diminishing return. Those diminishing returns don't fund reinvestment in manufacturing capacity. So if we don't have a continued flow of new genericizing medicines to keep the generic industry swimming, they won't be able to keep making all the other stuff. Same thing for everybody else. You're not going to invest in buffer stocks or anything else if it's a flat to declining market that is becoming less and less relevant as newer medicines come along. A lot of our shortages are really old stuff. They're the last thing left for certain patients, but there's newer, better medicines for some things that patient's not either relevant for or not using, or there's another reason to choose. And sometimes there aren't clinical substitutions. But when you think about this question of what do we do with onshoring or offshoring, or where the manufacturing is happening, I echo some of the previous speakers. The shortages aren't happening because a factory in a specific location is bad at their job. We have Delaware factories, we have factories in the US that we have generic companies that have gone bankrupt. This is not, they're American companies, it's not there. A lot of these overseas companies have US subsidiaries that employ American people. Finished goods are often manufactured here, even if the active ingredients are manufactured elsewhere. So those are also American jobs. So you're asking a question about something which is, I think, fairly political. It's outside my lane to a degree. But the real question is, why are the economics driving certain behaviors amongst the participants? Manufacturers, wholesalers, purchasers, and ultimately patients, because they're a part of this too.
Marta?
So, I mean, going back to the earlier question that you asked me, it's about potentially prioritizing. I will say I get very nervous that where we're going to land with Congress is raise your hand if you want to onshore, and then money will be thrown at it, and we'll pretend that we solved the problem, and we ended up wasting a lot of money. If we want to be, we need to be really strategic about how we think about it. There's been a lot of discussion about onshoring API into the US. Well, although the ingredients for API might still all come from China. So what problem did we solve? We need to be thinking about full supply chains. We need to be prioritizing the supply chains. I mean, it really requires a strategy. There's another piece. So for example, ASPR has funded during the pandemic a number of manufacturers, but also glove manufacturers and drug manufacturers. But it's one thing to build a facility, the economics is still there. How are they to survive? There's actually an excellent article that I recommend you read in the Pharmaceutical Manufacturer that talks about how, this is sort of the Kevin Costner movie, if we build it, they will come. Well, the problem is they are not coming. And so some of these manufacturers decided who got funded by ASPR now don't have the orders. One manufacturer actually does have a contract with this to make drugs for the stockpile, but they also are looking to do contract manufacturing. Some other manufacturers are switching entirely into doing contract manufacturing because there's just no way for them to be sustained, to sustain themselves in the current environment and the current economics in the United States. So if we're thinking about supporting infrastructure in the US and onshoring, we better think about how those manufacturers are going to survive.
Heather, the congressman talked about incentives. Do we need to, you think, have incentives in the United States as China has, as India has, to encourage production here?
I think to help our manufacturers compete at a level playing field, yes. To the point that Marta has, we don't know how the economics around it or the community around it will have to respond. It isn't the silver bullet that solves all, but it at least gets them in the arena to be able to compete in a way that they can with other global entities. We are in a global supply chain. I mean, every single pharmacy in America, every single health system in America, every single oncology, anesthesiologist, et cetera, every single product on those shelves more than likely have some type of international touch to it. And that isn't something that healthcare professionals are really taught or learn about or think that they're supposed to worry about when they're going to medical school, pharmacy school, nursing school.
Sorry, I just wanted to add, as I'm sort of thinking about, there's been a lot of discussion about what the government could do in terms of coming up with new programs, new incentives. What we haven't talked about is thinking about what government policies exist right now that might be contributing to vulnerability of supply chains and potentially to discontinuation. So I wanted to sort of flag too. There was a little bit of the discussion about the DEA. Unlike GLP-1s, which are really, sort of ramping up production, that's right, the Ozempic, manufacturers have a great incentive to expand capacity. And so they're investing billions of dollars, and it's hard for them to ramp up fast enough. With ADHD drugs, those are not hard to make drugs. There's plenty of manufacturers that are willing to manufacture these drugs. The DEA is not allowing the quota to rise. The quota for ADHD drugs has been flat for the last, I think, 5 years. And
they're concerned about abuse.
They're concerned about abuse. And so this is an issue of actually a government policy standing in the way in resolving a shortage. Another example where there are sort of concerns is Medicaid inflation rebates. And the way they're structured, a manufacturer might actually not raise any prices, but they might end up paying a penalty. Also, it depends whether they came on the market before April of 2013 or later, because then they have a different benchmark for the inflation rebates. And what this means is that they have a different level of potential margin in the market. I've testified with Senate Finance that if they were to actually put forward their proposals, the idea is that you pay hospitals more for reliability, for buying from more reliable manufacturers, but there needs to be pass-through to the manufacturers, right? And ultimately, we're doing this so that the manufacturers have an incentive to invest. So there needs to be some pass-through. And Medicaid inflation rebates and 340B actually stand in the way, because here we're going to have the hospitals will get paid more, but then they have to pay it back through 340B back to the hospital, right? So it just doesn't work. So there are other policies that really need to be addressed for us that are existing policies that we need to address. Yeah.
I want to bring Michael in, because we're going to go to audience questions here in just a moment. But Michael, before we haven't touched on this, and I understand they do play a significant role. Group purchasing organizations, what are they, and what role did they play in these shortages that we're experiencing?
Yeah. Well, so it's a good jump off from my past comments. If you think about the different institutions and purchasers in the system, they don't all have the same resources. And so your small little clinic in my little area in Maine doesn't have the resources of a large multi-state institution. So a group purchasing organization, GPO, essentially is an intermediary to negotiate on their behalf. Puts them in a pool with a bunch of other smaller institutions who can then come together, get a good price, and essentially they're your guy. So they're going around negotiating to get better prices for those groups who have less leverage.
So you're saying they're driving this race to the bottom in prices?
Well, yeah, and I mean, I think there's it's important to understand that for hospital products, there are some medicines which are costly enough that they have their own specific price, and then they're reimbursed in one way. And there are others which we have a system of bundling and DRG codes, reimbursement basis, the code words, that drive more of the race to the bottom. But I want to link this more to the triple dipping that seems to go on, because you have your 340B. These are discounts for hospitals that do care for the indigent, low-cost care, children's hospitals, cancer centers. But they get to buy at the lowest price in the market. Then you get Medicaid prices, which are the lowest prices in the market. Then you get the inflation penalties in these things. And policies all come in because something happened. So there's not lack of reason.
There is a reason.
But you have all of those added on, and then we have GPOs who are also trying to drive the best price in the market. So we have multiple reasons why there's a race to the bottom, but you describe it as if the price goes down, but it's not always the price. It's the purchase price, and then there's a reimbursement price, and there's a spread, and there's different things going on, and
So
it's complicated, and I'm dancing now with my hands. It's a thing we do. So GPOs have a critical role, particularly for low leverage purchasers, low leverage care providers in the system. That's what they do for them, is they level the playing field for them. And so it's really important to understand where the playing field is unlevel as we examine this. And it's not just for manufacturers, it's also for providers.
Right. Quickly, let's go to our audience question. Lisa.
We have one final audience question for the day from Nancy Headland from MedNavigate. What research might be ongoing to understand the impact of drug shortages on patients?
I mean, there are a number of studies, I would say not enough, looking at the impact that shortages have had on patients. It's going to vary by the drug, right? With some drugs, if you don't have it, you might die. With some other drugs, it will be just very frustrating. If you think about ADHD, there's, kids might have a hard time sitting in school and might not be learning. This is a very different thing that if you don't get your carboplatin, then you die early. I think because it's really drug by drug and specific, it's hard to sort of do systematic studies. There are some really great examples. There was a really great study of a drug that's used with sepsis, and the researchers looked at what happened after there was a severe shortage and patients were switched to another drug, and they saw mortality rates significantly go up. There's an unpublished analysis by the FDA that took the number of deaths that resulted and did an estimate of this one shortage in terms of the costs that the government uses in terms of the value of life. And the cost for that one shortage turned out to be $13.7 billion. This is just one shortage. We could probably use more studies like that, just so that we can really appreciate the scope. And then if you think about, how much money should we be willing to spend, that $13.7 billion is a good number to remember.
Well, I'm glad that that last question brought us back to the patients, because I think that's what this is all about. They are the ones, they and their families, who are suffering so much. I really want to thank you all, Heather, Michael, Marta, for joining us for this important discussion. Obviously, there are no quick, easy solutions, no silver bullets. It will be complex, but thank you for joining us. And just sit here as we wrap up. Joe?
Well, thank you all for attending today. I want to thank all of our wonderful speakers. I'd like to thank the Healthcare Distribution Alliance. And on behalf of the HDA and the Hill, I'd like to thank you all for coming, and the folks online. If you missed any part of this today, everything can be found at the Hill, at thehill.com. And the people in the audience, I welcome you to go next door and continue the discussion. And hopefully you'll join us all again soon. Thank you all very much.